السلام عليكم جميعا. Good evening everybody. In this video, I will share some of Salah bullets and how in anatomy and physiology and how is going in our course, how we are doing practice in Salah bullets. We'll start by anatomy. First branch of internal carotid artery. Answer is ophthalmic artery. Here is asking about the intracranial branches of internal carotid. As internal carotid has no branches in the neck, while in the brain the first branch is ophthalmic artery. You have another branches sharing in circle of Wells like anterior cerebral artery and posterior communicating artery and middle cerebral artery, which not sharing in circle of Wells. Next. Numbness over the lower lip after tooth extraction. This is very important question in the course. Is inferior alveolar nerve, which is a branch of mandibular nerve. This carrying sensation over the lower lip, and inferior alveolar nerve will continue as mental nerve when passing through mental foramina at the body of the mandible. Next. Loss of general sensation at the side or anterior of the tongue. This bilingual nerve from mandibular. As you know, tongue divided into anterior 2/3, posterior 1/3. Anterior 2/3, general sensation bilingual nerve from mandibular, taste sensation by chorda tympani from facial, while posterior 1/3 will be general and taste sensation from glossopharyngeal nerve. Submandibular gland injury and patient has tongue deviation ipsilateral side. Ipsilateral for tongue deviation to the right. Nerve injury for supplying motor for the tongue is hypoglossal nerve, the pelvis cranial nerve. Nerve injury during the submandibular gland surgery near the duct. Very important. You have three nerves can be injured in submandibular gland surgery. Number one, hypoglossal nerve, we discussed, marginal mandibular nerve, and lingual nerve. Hypoglossal nerve, the cranial nerve number 12, marginal mandibular nerve, this nerve coming from facial, one of the terminal branches of facial nerve. As you know, facial nerve inside the parotid will end by 5 terminal branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. Marginal mandibular can be injured in submandibular gland surgery. And the third nerve is lingual nerve, we discussed before, which is a branch from mandibular nerve. The most common nerve injured in submandibular gland surgery in general is marginal mandibular, while the most common nerve can be injured in submandibular gland surgery near the duct or when you are removing the stone from the duct is lingual nerve, because it turned around the proximal part of the duct. Most common nerve injured in cavernous sinus or it's inside the cavernous sinus and will be injured if there is increased intracranial pressure. The most one is abducent nerve, as it has long course. As you know, cavernous sinus has many contents inside it and in the lateral wall. Inside it, abducent nerve and internal carotid artery. Site of origin of vagus and ninth cranial nerve or glossopharyngeal. Medulla. To make it simple, the last four cranial nerves, 12, 11, 10, and 9 from medulla. The above, which are 8, 7, 6, 5, this from bones. The above two from midbrain, which are third and fourth cranial nerves from midbrain, fifth, sixth, 7, 8 cranial nerves from bones, and the last 4 cranial nerves from medulla. Unilateral soft palate and the tongue reduced sensation. Is asking also site of origin of the nerve. Soft palate, unilateral soft palate, this by glossopharyngeal. Tongue reduced sensation. Tongue reduced sensation by glossopharyngeal. Also the posterior one third. The posterior one third supplied by glossopharyngeal here is meaning the glossopharyngeal nerve, which is the ninth cranial nerve and last four cranial nerves from medulla. Okay. Now we are shifting for physiology, Salah bullets. Okay. I want to confirm that it's working. Yes, it's working. Okay. Now we can continue now our session. Patient has pyloric stenosis or excessive vomiting. He's asking about the electrolyte disturbance. Patient with pyloric stenosis or vomiting will have very important picture. Hypochloremic, hypokalemic metabolic alkalosis. Hypochloremic, why? Because loss of chloride. Why loss of chloride? Because loss of HCl was vomiting. Hypokalemic, number one, cause loss of electrolytes was vomiting. So patient will lose. What else? Patient with vomiting, this will activate the renin, angiotensin, and aldosterone system. This will cause pituitary to release adrenaline. Okay. Hello? Yes, voice back. Okay. So again, patient with vomiting, this will activate the renin, angiotensin, activate aldosterone system. So aldosterone will be released. This will cause what we named sodium and potassium excretion will cause potassium to be lost. So this will cause hypokalemia. Why metabolic alkalosis? Alkalosis because of high biocarb. Why in this patient with pyloric stenosis or vomiting will have high biocarb? Because of two mechanisms. A patient will lose chloride, the renal tubule will try to compensate or to maintain the electrochemical balance. So will do uptake of bicarb, uptake of HCO3. Again, when patient will lose chloride, your body maintains the electrochemical balance by doing reuptake of carb against number one. Number two, you are losing urinary juice. So pancreatic will try to retain its secretion. And as you know, the pancreatic juice is very rich with biocarb. Pancreatic juice is very rich with biocarb. These two causes of high biocarb in this situation. So patient will have metabolic alkalosis. Next scenario, patient has signs of ischemia of bowel due to mesenteric infarction. What's the picture you will see in EPG? Any GIT condition, mesenteric ischemia, peritonitis, sepsis, pancreatitis, all these conditions, patient will have metabolic acidosis. Why? Because here, due to this ischemia, you will try to get the energy via anaerobic pathway. Anaerobic pathway will cause accumulation of lactate or lactic acid. So lactic acid will cause lactic acidosis or metabolic lactic acidosis. Patient has pulmonary embolism or early salicylate poisoning. These two conditions, patient will have respiratory alkalosis. Why alkalosis? Because washing of CO2, hyperventilation. This patient will have hyperventilation, so this will cause washing of CO2, and this will cause respiratory alkalosis. Respiratory alkalosis. This will be discussed in details during the course when we are explaining EPG. Early salicylate. Salicylate poisoning, it has very important acid-base disturbance. Early, it will affect the respiratory centers, so will cause respiratory alkalosis. Late, after metabolism of salicylate in your body, will cause metabolic acidosis. So early, initially, ABG in salicylate, respiratory alkalosis. Late, metabolic acidosis. Patient has COPD, asthma, overdose of fluid, or sedations. COPD patient, it has characteristic ABG chronic respiratory acidosis. Chronic respiratory acidosis. Patient has DM and using metformin. This question came on April 2018 about what morphine is causing, or what he's writing the question by another way. He's asking about the ABG abnormality and asking which drug is causing that. Metformin is causing what we named lactic or metabolic acidosis. The question came, which drug is causing metabolic acidosis, and you have many options. So answer was metformin. Okay. The main determinant for the cerebral blood flow is what? Very important. Intracranial pressure. As you know, CBP or cerebral blood flow equal MAP minus intracranial pressure. MAP mean arterial pressure minus intracranial pressure. This question in every exam. So, what is the importance of CBP or cerebral perfusion pressure? What is the importance? You should keep this perfusion good because patient can go for secondary brain damage. How to maintain CBP? By two parameters. MAP mean arterial pressure plus intracranial pressure. So you should increase MAP to improve the perfusion, and decrease intracranial pressure to improve the perfusion. Okay, this topic is very important topic and will be discussed in details. Signs of increased intracranial pressure: vomiting, headache, edema, seizures, focal neurological deficits, plus Cushing triad. Cushing triad, very important, and every exam you will find this question. Patient with increased intracranial pressure will come with hypertension, bradycardia, and irregular respiratory pattern. So very important to maintain or to decrease intracranial pressure to improve CBP for patient. Okay. Intracranial pressure increased after trauma, so it can be decreased by what? As we know how to decrease intracranial pressure by this not increased after trauma. So how to be decreased or how to improve the patient by decreasing intracranial pressure and adjusting the mean arterial pressure. Okay. What is the physiological process to decrease intracranial? How to decrease intracranial pressure? What is the physiological process? Very important. Hyperventilation. Concentrate with me, and I will close by this question. Hyperventilation. To decrease intracranial pressure, you have many measures, like giving mannitol for the patient or giving dexamethasone. If traumatic increase intracranial pressure due to trauma, give mannitol. If due to tumor, give dexamethasone, because dexamethasone will reduce pre-tumor edema. Plus, in ICU, they are preferring to adjust the ventilator to be for BCO2, BaCO2 to be subnormal. What is the meaning of subnormal? The normal BCO2 is from 4.6 or 4.7 to 6 kilopascal. So better to keep subnormal from 4 to 4.5. Why? From 4 to 4.5. Why? This hypocapnia will cause what we name vasoconstriction or vasospasm, cerebral vasospasm or cerebral vasoconstriction. This will improve the CBP. So what is the role of hyperventilation? Hyperventilation will wash CO2. So BCO2 will be decreased. If BCO2 decreases to subnormal, this will make cerebral vasospasm or cerebral vasoconstriction. If you will do that, this will improve the perfusion, and this will decrease the intracranial pressure. And by this way, we end our session. Best of luck. If you will join us, you will find all Salah policy discussed by this way in all topics, inshallah, and everything, every line from what I told now is a question in the exam. Thank you for your time. مع السلامة. نلقاكم على خير.